speaker. Dr. Thomasson is a dentist in the Denver area. I've had the pleasure of having him in my office and meeting him on several occasions at seminars. As you probably know, I'm kind of a doubting Thomas most of the time. You have to show me something that works before I employ it. So when I heard about this device that he's going to lecture on, the anodyne machine, I said, could I use one of these for a month? He said, sure, no problem. So I started using it. Within, I use it on myself. I have a chronic shoulder problem, RSD of the shoulder. So I took this home the first night, and basically I slept with these small little pads on my shoulder. And the next morning, 50% of my chronic shoulder pain I had in 15 years was gone overnight with some little light energy. I bought one of his devices for my aunt who broke her neck last year, who was technically dead. They resuscitated her and they put her in a halo collar. And my mother took her to Florida for rehabilitation, and she wore his little device, the home care device, every day for 2 or 3 hours a day over her carotids, brachial plexus, base of her neck. And my aunt started to walk without the walker within 2 or 3 weeks of using this device. The sensation in her hands, which there was a paresthesia in her hands, is now gone. And the only remedy she had besides Florida sunlight was this device. So this is a truly amazing machine. He also was in my office one day and we had a very difficult patient. His knowledge of TMJ and facial pain is quite astronomical. I was quite impressed. So without further ado, the next lecturer is Tom Thomasson. He's going to be discussing enhanced hard and soft tissue recovery, both pre and post cavitational surgery, utilizing monochromatic infrared photo energy. Thomas.
Thank you.
You have to turn your mic on.
I did already.
Are you on?
I think.
Chris, is he on?
Yeah, it should be. Yeah.
All right, you're on here.
Okay.
You don't have slides. Come on, Rambo, come on. Come on, let's go.
Rambo's my worst patient. Or my best. I don't know how to do. I'd like to share with you some experiences and some research that I've been involved with the last 8 years. This technology was developed 8 years ago in Denver by a gentleman whose father lost his foot and his leg in his life to diabetic ulcers. He happened to be a horse groom and felt that he had seen way worse wounds on horses healed than his father had died of, and he got kind of angry and started doing some research on the internet back when it was a whole lot more difficult to get on, using, I think, Unix to do the research, and developed the systems that I'm going to discuss with you today. I do not have any equity interest in the manufacture of the device, nor do I have any equity interest in Rocky Mountain Health Technologies. However, I do have family members that do work with Rocky Mountain. The research that I'm going to show you, I want to back up only with science, no hype, hokum, or hyperbole. If it's an opinion of mine on what's going on, I'll be sharing that with you as well, and I welcome some feedback from any of you here. I have the utmost respect for a great number of you, having learned most of what I know from a great deal of you over the years. So I'm deeply appreciative of being here. Thanks to Carol Netterana and also Chris Husser, and let's see if we can have some fun. The two systems primarily involved would be the Anodyne Professional System, consisting of 4 application pads of superluminous diodes, and the home system sent with the patient, non-adjustable, with typically 2 application pads of 60 superluminous diodes each. There's also an intermediate system that runs 4 pads, which if you have an interest, you can visit the booth next door. The pad is flexible, so it can be applied to any conforming body part, either convex or concave, and it is in direct contact with the patient. These are just some examples of Denver General Hospital applications. We have external fixation here on the upper left. We have some of the physical therapy and occupational therapy applications and multiple patient applications with the same device at Denver General. Denver General Hospital has been using this device for about 5 years now. Most of the research I'm sharing with you today comes from the Department of Physiology at the University of Colorado School of Medicine, Dr. Thomas Burke. And he's been gracious enough and patient enough with me to teach me this stuff over the last few years. We're dealing with the photonic spectrum, primarily and specifically the near infrared area. It is infrared, it is invisible, but it is near the visible end of the red spectrum. The physics involved: photons do have mass and momentum. I want to touch a little bit on how photoenergy works, then we'll go directly into the mechanism of action and then discuss some of the effects. The mass and momentum that the photons have do transfer energy at the atomic and the molecular level. The wavelength of these photons will depend or will impart specific energy quanta to the tissue, and that will make a difference in how the tissue responds to the photon. Photoenergy does interact with tissue. In plant life, it's obvious we have photosynthesis. We have melanin production and exposure to sunlight in tanning and or burning if it's exposed too long. And we have color recognition through light-gated ion channels in our eyes. Color recognition is, as every other photoenergy-dependent reaction, dependent upon wavelength and energy density. We may have the proper wavelength to see the colors on the wall, but we also have to have the proper amount of energy, not too much and not too little, to be able to determine that that wavelength is in fact there. So the combination of wavelength and energy density is essential in any photochemical change. Characteristics of interaction are based on two primary laws. The first law of photochemistry, the Grothe-Straper law, is that wavelength dependency is essential. Only the light which is absorbed, whatever the wavelength may be, will act photochemically. If the photons are not absorbed by the tissue, there will be no interaction. It doesn't matter how far they penetrate, it doesn't matter how many photons you give the tissue. If they are not absorbed, they will not produce an effect. The Bunsen-Roscoe law, the energy dependency law, is that a photochemical change is proportional to the intensity, as we discussed a moment ago, and the time of illumination is also a factor. When we include the time of illumination in the equation, we then go from talking about, for example, milliwatts and square centimeters to joules per centimeter squared, which is in the real gold standard for measuring how much energy is imparted to tissue. It includes the time factor as well. For optimal interaction characteristics in photochemical change due to photoenergy, we need to have perpendicularity to the treatment area. We also need to be in contact with the area because light, photoenergy, degrades as a function of distance. We need an appropriate energy density. Without the energy density, as we mentioned, that is appropriate for that specific photochemical change, nothing will happen, or what happens will not be effective enough to produce the result desired. We need a uniform and homogeneous delivery. We don't want hot spots or cold spots over the area that we're trying to deliver photoenergy to. The therapy pad, as I mentioned, has 60 monochromatic infrared emitters. Each one has 10 milliwatts per square centimeter output, so we have 600 milliwatts per application pad. There is a uniform delivery over the surface of these pads. They do not vary more than 1/100th of a percent over each of the application areas. And it does conform to and maintain contact with the patient. This was developed out of 30 plus years, beginning with Mester in Eastern Europe, of soft laser research. And soft laser is photoenergy. The comparison of the two, the soft lasers can be technique unfriendly from a standpoint of operation. They are definitely producing a result and have done so for a long time. The diode arrays are applied and left unattended. They can also be used over the cornea or the eye without any potential tissue damage. The lack of consistent effects with the soft lasers, in my opinion, is why FDA has not cleared any of them. And I think that it has to do with the technique and the operator and the application. I think that the reports and the varied reports we see in the literature are a result of that directly, because photoenergy does produce an effect. There's no question about it. There is potential tissue damage in some cases. There is no tissue damage, as I mentioned, with the diode arrays. No FDA clearance with soft laser. The diodes were FDA cleared in March 1994. Therefore, there is an insurance reimbursable CPT code. In summary, photoenergy does not have to be lased to be effective. If it were lased in this particular device, it would not have been FDA cleared. As well, this device produces a warmth component, which raises the skin temperature about 5 degrees centigrade in 20 minutes, and that was essential for FDA clearance to be included in the infrared category as well. A laser, soft laser, does refract, scatter, and absorb when it first enters the first micrometer of tissue, so it is no longer lased. And the action is absorption, not penetration. The growth of Draper law we discussed earlier. There must be absorption. Penetration is useless if it is not absorbed at some point in the tissue. Invariably, because of all the modalities that I've been associated with over the years, being based primarily on penetration, we still get questions about how far does it penetrate. This is a fairly local resident. It's a West Coast animal, an elephant named Candy in one of the zoos, 51 years old. Candy had an arthritic carpal joint and was unable to walk, and when she did walk, she had to use her trunk as a cane. She also had a decubitus ulcer on her hip. This was reported about 3 or 4 times on national TV, Real TV, and a couple of other programs. Because once the arthritic carpal joint was treated with the device, then the decubitus ulcer was also treated, and the elephant now walks normally, has no ulcer, and does not take 8,000 milligrams of ibuprofen a day. It's a big, big animal. I've never taken more than 6,000 myself. The next part of the research after determining that there was a photochemical effect was done on equine athletes, racehorses, rodeo horses, hunter jumpers, and that type thing. And as I mentioned, the man who developed this technology had a history in this area. The very first wounds that were treated on the legs of the horse. They were distant from the heart and had poor circulation. So we wanted something that was difficult to heal, that wasn't easy to get healed whether you used the device or not. And all mammals essentially heal in the same manner with the growth factors and fibroblastic activity and so forth. This was the first animal ever treated. It was a barrel racing horse. You can see a complete degloving injury here, the lateral capsule of what would be our knee, the knee capsule itself. This wound extends all the way around the other side of the leg, half as big as what you see here. It got caught in a trailer and panicked and started moving its leg around repeatedly and completely degloved the joint. Dr. Charles Vail, the past president of the American Equine Practitioners Association, knew the family that had this animal. It was a champion barrel racer. They were concerned they would have to put the animal down. Colorado State University Veterinary School estimated 2 years of treatment and $50,000. They said it would be pasture sound, but it would never barrel race again. And you can see the results over the 6 months of treatment. This was not surgically repaired. You can see only a pencil line of what used to be a wound. The only thing that was done was a betadine scrub occasionally in the wound bed to clean it up. No antibiotic salves, no oral or injectable medicines of any type were used, and no wraps. You'll get to see the progression of the healing over the 6-month period. We get normal tissue, normal epithelialization in the granulation bed of the wound, and then we get normal hair growth over the epithelial tissue that occurred. The reason I'm showing some of these things is because we are all interested in healing our patients. And if we can see the visual, when we discuss the molecular, perhaps it'll be a little easier transition. This was a concern to the veterinarian, the white area here and up in this area. Those turned out to be not a fungal infection, but normal epithelial islands in the middle of the granulation bed, which had never been seen in wound healing in animals before. These photos were taken weekly and scanned into the computer in order to get the changes that you see over 6 months in just a few seconds. And the horse returned to barrel racing. How does all this relate to what we're interested in today? And that is hard and soft tissue recovery. The mechanism of action of this device is specifically releasing nitric oxide and specifically releasing that nitric oxide produced by the constitutive or the third form of the synthase. The wavelength and energy density produced is specific to break a bond we'll discuss later, and we have the proof of that with research at the Colorado School of Medicine, both in rats and humans. and as well at National Jewish Hospital. This photograph of two X-rays was responsible for the discovery of the mechanism of action. For 5 years after it was developed, didn't have a clue why this thing worked. It worked well. We got great results in a myriad of conditions, and it was unbiased and unprejudiced in the patients, whether the skin was dark, light, yellow, red, it didn't seem to make any difference. And then Tom Burke, that I mentioned earlier, at the Colorado School of Medicine, saw this particular presentation. This is 48 days apart. This periosteal separation, these were taken, by the way, at University of California, Davis, healed in 48 days, and a sequestrum of bone resorbed. That was really exciting. And we thought we had something that was really cool because we had a lot of fibrous changes and a bony change in resorption of the sequestrum. Well, Burke wasn't even interested in this. He looked at the marrow area of the bone and he said, how controlled were these X-rays? And they were very controlled, specifically with fresh solution, the right temperature, same machine, and so forth, because it was an experiment at a major university. What he saw was an increase in bone density of 30% in 48 days. He said, do you know how this works? We said, no. And he said, I know how your device works. He said, give me a week. So 1 week later, he had the molecular mechanism of action. What he saw was a reversal of essentially osteoporosis, or an increased bone density depending on your baseline from where you start. He knew that that could only happen one way because he had done 8 years of research with NASA to reverse osteoporosis in astronauts in weightlessness. American astronauts get osteoporosis almost immediately upon entering space, and they have tried for years to use a myriad of salves, medications, and all sorts of different applications to keep these astronauts from getting osteoporosis. Well, Tom Burke had the answer for them, but they weren't interested in it. Russian astronauts, incidentally, do not get osteoporosis in space. And the reason the Russian astronauts don't get osteoporosis is because they breathe compressed air, atmospheric air. American astronauts breathe compressed oxygen. The Russian astronauts get nitrogen. And you see where I'm going with this? They can produce nitric oxide. Nitric oxide is the single molecule responsible for laying down bone. If there is no nitric oxide to signal the osteocyte to upregulate the osteoblastic activity, no bone will be laid down, period. In fact, you'll get osteoclastic activity immediately in the absence of nitric oxide upregulating osteoblastic activity. There are 3 forms of nitric oxide synthase. Now, some of this in the literature, if you research it, will be a little confusing because the nomenclature has changed over the years. In 1986, nitric oxide was first discovered, but it was unknown what the molecule was. It was called EDRF, endothelial-derived relaxation factor. We now know that there are 3 forms of the synthase. We're not aware of any other forms, but there's probably as much research in this area worldwide as there is in any other in biological medicine. The BNOS, called brain nitric oxide synthase, because it was discovered there, not because it's only there, is now called NOS1 and produces a neurotransmission effect. The second form is INOS, or inducible, or inflammatory nitric oxide synthase, now called NOS2 more commonly in the literature. This is a bad individual. You don't want this to happen. This is the cause of glaucoma, arthritis, asthma. This is what you want to have down-regulated, not up-regulated. And then we've got the good guy, the NOS3. Originally, constitutive was the name. Endothelial has also been used as a name for this synthase, but is now more commonly called NOS3. You can't get enough of this. This is the arbitrator. It will upregulate and downregulate body systems depending upon the need. It is not a stimulator. It is not an inhibitor. It is a moderator. Now, this is a question that I would ask if I was sitting out there. How do we know that we are only releasing the nitric oxide produced by NOS3, or the constitutive form of the synthase? We know from Doppler flow analysis that we've done that the blood flow in humans increases seconds after application, and I'll show you the Doppler test in just a moment. Only the constitutive produced form of the constitutive synthase producing nitric oxide can give us this effect. Plasma nitric oxide increases in humans minutes after application. The inducible form takes hours to appear after an insult, inflammatory, cytokine, or otherwise. So we do know that the effects that I'm about to show you were produced specifically by a nitric oxide produced by NOS3, or the constitutive form of the synthase. This is the Doppler test that was done at a lymphology conference in Puerto Rico. This is the baseline of blood flow. Each of these vertical lines represents 5 seconds. The Doppler was placed just above the ankle on the anterolateral part of the leg, and this is dorsiflexion of the foot, producing an increased evacuation of blood flow from the leg because of muscle contraction. This is the baseline of returning to normal when dorsiflexion is stopped and all activity is still. At this point, the infrared pads of the anodyne system were applied to the leg. Within 2 seconds, we have an increase in peripheral bed capillary evacuation on the venous side. The second time, the dorsiflexion was again accomplished, and rather than applying the pad down here, we first applied it at the very beginning, and you can see the difference in the volume of evacuation from the original baseline with the pad on as opposed to without it. I've also done a test with, and I don't want to use her name without asking her, but I'll do it anyway. I don't think she'll mind. Don Ewing used a biomeridian machine, and we did a lymphatic evacuation test on myself, and we got the same results in the mandibular area. Less than 2 seconds, we returned compromised lymphatic drainage to normal. Lymphatics and veins evacuate fluids exactly the same way, and we'll discuss that in a moment as well. I want to show these things because what we're trying to present needs to be based on science. We need to have factual information that's not based on happy and sad cells or whatever you may have been told in the past. And maybe some are happy and some are sad, but what we want is science and molecular mechanisms of action and photochemical and physiology interactions that make sense and prove what we think is right. We then went to rat plasma and saw what the effect of the infrared application of the device had on the rats. And we had a significant increase in nitric oxide release with rat plasma. We then put the rat blood cells out of the plasma in saline, and we got the same result. We then took the rat blood cells and made ghost cells of them. We lysed them, took the hemoglobin out, and resealed them. Did not get the effect as you see. This was done to show that we were, in fact, releasing the nitric oxide from hemoglobin. In the humans, this is plasma. Now that we know it's coming from hemoglobin, with one pad applied of the anodyne system for 20 minutes, there was an 8% increase in nitric oxide elevation in the plasma. With 2 pads applied, there was a 28% increase. It wasn't additive, it was exponential. Now, we haven't done the 3 and the 4 pad placements yet. Some of the information you're seeing today is even less than a few weeks old, but some of it's about 2.5 years old. So the point being, going back to the laws of photochemical interaction, not only are the energy densities important, the wavelength of utmost importance, but the time of illumination, which gives us joules per centimeter squared, is also essential. So we increased energy density by doubling the pad, left the time of illumination. Whether or not this would come to 28% with longer application, I don't have that answer yet. National Jewish Hospital in Denver is doing an asthma study, free gratis, because of the effects they've seen with this device on asthma in their patients. What you see here is nitric oxide synthase, exhaled air in an asthmatic. Application of the infrared device, and it came down. It did not increase. That's because this is the inducible form or the inflammatory form that's causing the problem. The constitutive form down-regulates that. And the asthmatics that we've treated have gone 18 hours without any inhalers or any type of medications whatsoever, as long as they weren't insulted by allergens or smoke or something that would cause an insult to them. In a normal individual, there's a slight change, but in the same direction.
Where are the pads placed?
The pads placed in the National Jewish Hospital study are going on either side of the sternum. The pads placed for the plasma studies on humans were placed right over the jugular and carotid area, and the draws on the blood were done in the antecubital vein area. So our mechanism, we have near-infrared energy, specific wavelength, specific density, irradiating red blood cells and the endothelial lining of the blood vessels, releasing nitric oxide produced by constitutive nitric oxide synthase. The presence of nitric oxide to be available to be released is in hemoglobin, as we mentioned. Specifically, on hemoglobin, there are two sites that nitric oxide can bind, both of them on the beta chain, one on each beta chain, the 93rd position, the cysteine group. Endothelial cells of the blood vessel walls and in the lymphatic ducts also contain nitric oxide produced by NOS3. And cellular nitrosothiols transport and bind nitric oxide produced by NOS3. The nitrosothiols are basically sulfhydryl groups bound to nitric oxide. One of the functions is vasodilation of NOS3. And I want to just do a brief sort of little animation here of how this occurs. And the reason that this is important is because this is the same mechanism of action that relaxes a skeletal muscle spasm and will dilate the lymphatic system. This is the only device known that actually increases the diameter of the lymphatic ducts. And this is also the basis of the Nobel Prize in Medicine being awarded 2 years ago for the discovery of blood pressure regulation by nitric oxide. This is the pulse from the blood pumping through the coronary artery. That mechanical flux creates a change in the diameter of the vessel, which releases nitric oxide, which then in turn tells how much blood pressure we need to have. With the buildup of atherosclerotic plaques, the smooth muscle around often goes into spasm. Then we have an angina attack with chest pain. We give a nitroglycerin tablet to relieve that, and it's a very fast-acting situation. The reason the nitroglycerin tablet acts so fast is because it releases, guess what? Nitric oxide produced by NOS3. Here's the mechanism of action. We have a neurotransmitter. It could be acetylcholine on a receptor site. That doesn't seem to be coming out very well. This is a smooth muscle down here. You should be seeing muscle cells. I don't see anything but white. Do you see any muscle cells out there? Well, that's not cool. I'll show you this at the booth if you want to come by later. Nitric oxide is released when that occurs. The nitric oxide then binds with guanylate cyclase. When this occurs, we get a dephosphorylation of cyclic GTP or GTP into cyclic GMP. That in turn activates myosin. When the myosin is activated, we get relaxation of the smooth muscle. That's the mechanism of action that we have seen with the nitroglycerin tablet on smooth muscle in the coronary artery. It is the same mechanism of action that relaxes a striated or skeletal muscle with a muscle spasm or trigger point. And it is exactly the same mechanism of action that occurs to relax the lymphatic ducts and give them dilation. Another function of the NOS3 form of nitric oxide production is platelet adhesion is decreased. And this is of great interest to me, and I know it would be of a lot of you in the audience. We decrease the platelet clumping because the nitric oxide removes the adhesive nature of the platelets. It's also anti-inflammatory. We have a reduction of the inflammatory process when nitric oxide is released as long as it was produced by NOS3. One of the reasons is macrophage activity is increased. When 20 minutes with application over the carotid arteries and draws at the antecubital vein, we can get a 400 to 900% increase in monocyte count in the blood. depending on the patient. That is not because we produce more monocytes. We just removed, again, the adhesive, sticky nature of these guys hanging around the endothelial wall, and they became mobilized much more than they normally would be. So therefore, we get an increased monocyte count. We get an increased number of macrophages for better tissue debris and evacuation of toxins. This is antiviral and antibacterial. I know it sounds too good to be true, doesn't it? It is antibacterial because we get also a 400 to 900% increase in reactive lymphocytes, which then become plasma cells and T cells and B cells in the thymus and the bone marrow. The antiviral portion occurs because the nitric oxide that's synthesized by NOS3 and in activated macrophages that we just discussed diffuse into the infected cells, and it inhibits the viral proteases that process the viral polyproteins. The virus cannot replicate. So we don't really kill the virus, we just stop it from reproducing. We also have pain decrease, which is a nice patient adjunct with this device. Pain decrease occurs primarily in an acute situation through COX-1. The cyclooxygenase pathway with prostaglandin H2 and I2, we get an acute vasodilation, which I just discussed with you. So we have decreased swelling. Less edema is less pressure on the nerve. That's a very physical, easy way to get less pain. We also get better nutrients, so we get a more normal membrane potential with the nerve. We don't have a nerve at negative 20, 30, 50, 60, 70 millivolts that's easily fired. We have a nerve that's now getting restored to negative 90 millivolts where it should be, so it doesn't fire as easily. And also nitric oxide inhibits non-cholinergic and non-adrenergic nerve firing in general. Tissue remodeling long term, which is of paramount importance in cavitational patients, occurs through COX-2. The cyclooxygenase pathway 2 and prostaglandin E2, when activated with NOS3 produced nitric oxide, activates a nuclear transcription factor. For those of you interested, it happens to be NF-kappa B, and this nuclear transcription factor promotes two early response genes, CFOS and ERG. These response genes are responsible for long-term bone and muscle remodeling. The studies are in place on that. We also know we get neurogenesis and nerve regeneration with this, but we don't have the studies in place. But the clinical results are obvious. So the benefits, we have faster recovery, reduction or elimination of scar tissue, improved osseous integration, reduction in pain medications, and we're treating a cause rather than a symptom. The reduction and elimination of scar tissue we have done, we'll touch on in a little bit too. We've also done some biopsies on the equine athletes, and we found that with long-term application of the device, the cross-linking in the collagen in the injured and wounded area actually realigns to parallelism, and we get better tensile strength and mobility. So some effects: vasodilatation, anti-inflammatory. We mentioned decreased platelet adhesion and fibroblastic proliferation as well as osteoblastic proliferation. In the reality of treating patients, the first patient that was ever treated with this device in a clinical hospital setting at the VA hospital in Denver was a venous stasis ulcer patient, a veteran who had a wound on his leg for 13 years. It had not healed. The VA had treated this for 13 years. He had had 2 skin grafts, platelet-derived wound growth factor. He had had Una's boots, Regranix, all sorts. They've thrown everything at him. HBO, he just would not heal. They didn't think that this device would work either, so they didn't take any pictures. The original wound is the blue outline. In 6 weeks, it was half its size, from 40 square centimeters down to 20 square centimeters. And then you can see the result. This is hemosiderin pigment left over from lack of venous evacuation over the years. This is an adult white male. You can see the progress of the healing. Now, the interesting thing about this is this patient treated himself at home. There was no controls. We had no way of knowing how long he used it or what he was going to use it, or if he would. He came in with very filthy bandages, urine and flies and so forth in it. It was really unfortunate, but that's just the type of situation that you deal with in some of these cases, especially when you're doing home care with it. Excuse me, I didn't want to do that. You'll be able to see the dynamics of how his wound healed. It took 11 months, but again, he had been under 13 years of treatment with this. Another interesting thing about this wound healing is that no one really realized until this software was developed that wounds migrate as they heal. They don't stay static in one place on the leg, and you'll see that as the dynamics of the wound move around. You'll see apposition and you'll see wound bed granulation and epithelialization, especially in this last part here. I'll just show you one quick thing. That right here, we have the same thing that occurred in the horse wound. We have epithelial islands, normal tissue in the middle of the granulation bed. So we were able to predict where that wound was going to heal the fastest next. But originally it was thought it was a fungal infection. Again, I want to show these because these are the most difficult wounds to heal on patients. And if we can heal these, then we have hope that there's some other things that we can heal as well. This patient had the ulcer present for 6 years. This is also at the VA hospital in Denver. It resolved in 7 months with the patient treating themselves at home. This one didn't have any marginal apposition. It was purely epithelialization from the wound bed straight up. These pictures were taken a week apart, always with a centimeter ruler, and the computer computes the number of pixels in the wound so we know within 1/100th of a square centimeter what the change was from week to week. 40 years on this guy's leg. Unbelievable how these people suffer. It's just unreal. You can see the progression of the healing. This one healed in 5 months. And you might also notice the size and diameter of the leg here as compared to here. There's a lot less swelling. We got the lymphedema out of the leg as well as treating the wound. This one healed with a combination of marginal apposition and granulation bed epithelialization. Got some very happy patients at the VA hospital in Denver. Diabetic amputation healing, which is a horrible thing for us to see and to treat with patients. And as I mentioned, the man who invented this was angry because his father lost his leg, not in that order, of course, to diabetic ulcers. This is the same patient, and the reason this is of interest is there is a non-healing wound distance here. Sutures are still in 2 months after the great toe was removed. The heel has a pressure ulcer or a decubitus ulcer, and the top of the foot, here's that same suture, has a stasis ulcer, a venous stasis ulcer. 3 different type of wounds on the same patient. She'd been in a wheelchair for 2 years. They all healed in 5 months with the same quality of remodeling. So the device was not prejudiced, as it showed us, to a specific type of wound. This individual was sent to Denver General Hospital to have his big toe amputated. As you see, he got to keep it. The scleroderma wound was worsening over a 4-month period. It resolved in 14 days. I apologize for the quality of some of this. I just got this projector this morning, and I guess it needs to have some adjustment, but I'd be happy to show you any of these up close on the computer during the conference if you have an interest. Achilles tendon rupture, dealing with fibroblastic activity being upregulated, collagen being laid down, matrices being formed. Robert Russo is a mid-50s gentleman in Denver. He had a removable walking cast after his Achilles tendon ruptured playing racquetball. He began to use the device 1 week after the surgery repaired the Achilles tendon, and he was jogging 8 weeks later. This is normally a 14-week process. This is a professional athlete up in the mountains in Colorado. He did the same thing by filming a commercial in Arizona running. He was in a hard cast. I didn't see him until a week after the operation. He had a hard plaster cast on his leg. We talked the surgeon into cutting a hole in the back of the cast over the surgical incision. He used the device every day for the next 6 weeks. When they removed the hard cast, he had full range of motion, which was unbelievable. He was supposed to wear a walking cast, but being the type of person he was, 3 days after they removed the cast, he went bicycling. I don't have science to back this up, but this is my patient. It just thrilled me to death to see this, and I have a theory on why it occurred. This little girl's mother had 2 episodes of post-herpetic Bell's palsy. So did her mother's sister and the grandfather. I had never heard of such a link in a family like this. She got herpes, and then she got Bell's palsy. She came into me, she got it on the 7th, she came in on the 12th. I treated her once that day and then gave her a home system to take home with her, and you can see how she came in on May 24th. She had actually had full resolution on May 19th, 5 days earlier. What I suspect is what we discussed earlier. I suspect that the nitric oxide that was released by NOS3 production inhibited the viral polyproteins so that the virus couldn't replicate long enough to cause damage permanently to the nerve. I don't know that that's true, but that's my suspicion based on the science that we have available to us. This just has to do with some inflammatory conditions I used to treat with injection and radiofrequency neurolysis in the suboccipital area. The retroorbital type of headache, photophobic, paraorbital, nausea sometimes associated with it, often confused with migraines and sinus headaches. But I used to inject and neurofrequency neurolyze here, and now I have only had to inject maybe 6 patients this whole year by using this application. And myospasm we already discussed in the heart animation. For soft tissue manipulation, for those of you who do this with your patients, there'll be decreased pain, decreased muscle spasm, and decreased digit fatigue for the practitioner if that happens to be part of the application that you're doing. So the indications for use for this device, if your therapeutic objectives are to increase circulation, reduce inflammation, decrease the edema, enhance the soft tissue remodeling, and the osteoblastic proliferation, you will get all of those with the application if the protocol is properly followed. I mentioned this earlier, 490% increase in monocytes and reactive lymphocytes within 20 minutes. We saw that angry looking little guy earlier too. It's good to have a lot of those guys around. So the therapeutic benefits of the localized release of nitric oxide in wound healing, increased circulation, again inflammation, reduced edema, improved bone density, which is one of the big reasons that we're all here trying to achieve some of this, and this, antiviral, and reducing pain postoperatively. The importance of nitric oxide, it's present in every life form known, from slime mold to humans. It was originally called endothelium-derived relaxation factor. It was awarded the Nobel Prize for Medicine in October 1998 for its discovery by 3 gentlemen in 1986, and it took about 12 years of research to realize what they had actually stumbled upon. There are actually about 30,000 articles as opposed to 20,000 out there. If you get on the internet and want to do a search on PubMed or Medline or something, when you type in nitric oxide, type in another subject with it because you'll be overwhelmed with the response. Be specific in what maybe your interest is in, whether it's juvenile arthritis, diabetes. It can be any one of those types of things. So the pre-surgical benefits for cavitational patients. Less inflammation, less bacterial activity, less viral replication, less platelet aggregation, more osteoblastic activity, more fibroblastic activity, angiogenesis, new blood vessels, and more lymphatic evacuation. Now the interesting thing about this slide to me is that the pre-surgical benefits and the post-surgical benefits are identical. We want the same thing to happen before or after surgery. Hopefully I can give you some parting pearls. Some, what I like to think of as some new science for some old observations that we've had. Before we go into this, are there any questions about some of the things that we've covered at this time?
Couple questions. Do you use this for paresthesia?
Yes, I have. And I've had, we've used it for paresthesia. We've also used it for, as Chris mentioned on his, I'm sorry, your mother? Your aunt, your mother's sister. And also on posterior tibial compartment syndrome, 14 months after being released from care. The lady had essentially no leg function, and she now has normal function, rock climbs and water skis, so motor as well as sensory reactivation has occurred. Whether it was remyelinization, reactivation, or neurogenesis, I don't know.
How about, have you ever used it over an organ for like viral hepatitis or something with diabetes over the pancreas?
There's a lot of research going on in a lot of areas. I will touch on this as a personal note. I have a patient who was 25 years brittle diabetic on 39 units of insulin, type 2 diabetic. And I treated her 13 times over a 6-week period 3 years ago. She personally took herself down to 18 units of insulin during that treatment time just because she monitors her blood glucose so regularly. She felt she could go lower. Her physician denied her that opportunity. 2 years later, she changed physicians because of an insurance change. The new physician did a complete new blood study on her. He called her up 2 days later and said, if I didn't have your records, I wouldn't believe it, but your blood proteins are all as normal as mine, and I'm not diabetic. That's one anecdotal incident, but there are a number of incidents in the literature of type 2 diabetes being reversed using infrared photoenergy.
He's putting a pad over the...
She was treated on the face and the neck because there is a systemic effect as well. Yes?
What frequencies do you use on the line? Do you mix frequencies?
There's no mixture of any frequency, but the wavelength is near infrared at 890 nanometers. Yes, sir?
There's been information that drop of sexual activities connected to nitrous oxide. Have you done anything with that?
Of course. I'm not as stupid as I look. The nitric oxide activity is it's a responsible agent in Viagra. Viagra releases nitric oxide specific to that site. There's a gentleman, God rest his soul, he is dead now. He was practicing TMJ in Chicago and had a car wreck. But he was diabetic, had already lost his toenails, and we treated his diabetic neuropathy at a conference. In one treatment, he had a significant improvement in the diabetic neuropathy in his feet. He claimed 70-75%. And this is an anecdotal evidence. Again, I'll give you the science and I'll just tell you the stories if you like. He called me about 5 weeks later and he said, "Man, I don't believe this." I said, "What?" He said, "My magic wand is magic again." And I mean, this changed his life. I mean, it just made a huge difference in the quality of life for he and his wife. And I mean, that was a real blessing to me. And he was dead serious. And unfortunately, not long after, he did die in a car wreck. Yes. I didn't ask specifics of protocol. I thought that was remained between him and his wife. Yes, sir.
Where did you place the pad when you were treating the young girl with Bell's palsy?
Just like we saw over the TM joint, and the second pad from the gonal area along the mandibular border.
You ever treating one with blepharospasm?
No, I haven't. I've treated torticollis, but can't say that I have.
Torticollis, how many treatments did you use?
We used it on an ongoing basis. The patient ended up getting the device for home use, buying it, and used it on a daily basis. There was not a reversal, but there was a reduction in symptomology. Yes?
What about nutritional supplementation? What about using arginine as a concomitant adjuvant for increasing nitrous oxide or nitric oxide output?
L-arginine as you obviously know, is the essential amino acid necessary for nitric oxide production in the body. However, when given even up to 17 grams a day of L-arginine in the kidney studies, we do get an increase in nitric oxide production initially, but then it drops off even with continued use of the L-arginine. It's called, in fact, there's a paper that you could find called the nitric oxide paradox, or the L-arginine paradox, excuse me, that was interested in that very premise. But that's an excellent question. Yes, sir.
Do you also do TMD treatment yourself?
My practice has been limited to TMD since 1980. I've been privileged to diagnose and treat about 5,000 patients.
So even with the some of the symptoms you tied in the TMD with some of this?
I'm not sure I understand your question.
Well, some of the symptoms you're talking about, the torticollis, is often a structural component to it. So I'm just wondering if that's been used with it or not.
Yes, sir. And I wouldn't have gotten these patients had they not had a TMD situation to begin with. So, yes, the device won't reverse a structural or architectural dysfunction like a stenosis, for example, although I have to back up on that when I show you some of the long-term tissue remodeling in muscle, bone, and nerve, and also in the collagen on the biopsies that we did. So there is some change long-term. We're working on if we can get to severed nerves quickly, and it's very promising on what we've seen so far at the School of Medicine in rats in rejoining nerves if we don't wait until that area has fibrosed or grown over and they can regenerate more quickly.
With your Bell's palsy case, it sounded like the decreased inflammation may have had a lot to do with that one. But did you do any structural work with that patient?
The patient was already under treatment. That's how, and I'd already treated her mother 2 years after her Bell's palsy. We only got about a 30% resolution of her paralysis 2 years after the fact. That's why her mother immediately brought her in. This little girl was under my care at the time that she got the herpetic lesion.
Any cranial work with?
I have a partner who does that, Jim Kennedy.
Since most of this is long-term therapy, do you sell these units or do you rent them out or what?
I personally don't sell them. I find it a bit of a personal conflict in the office. What I will do is treat them in office if they're nearby. We have a number of patients that come from long distances, and I will lease them the home device from my office for anywhere from 1 to 2 months, sometimes a little longer. If we see after removing the treatment that they have either fibromyalgic or RSD problems, then I'll write a script for them and they call Rocky Mountain, and Rocky Mountain deals with their insurance company on getting them the system, or they may purchase it themselves. Yes, Dietrich?
Most of the scientific findings you showed us are true for all infrared devices like the infrared lasers and sauna therapy and so forth. Has anyone ever looked at comparing the different devices sort of in terms of the speed of recovery of symptoms and stuff?
I'm not aware if anyone's done that or not. I agree with everything you said. I can't make a comment on the far infrared, but definitely the near infrared, you're absolutely right. And this was developed out of the 35 years of research and use of soft lasers because there's some phenomenal effects that you see. I think the difference is the consistency of effects that we've seen because of the increased energy density and the homogeneous large area that's being affected. Therefore, we're getting much more of the effect on a consistent level.
Just one last question.
Sure.
Have you seen in the jaw any significant remodeling of bones, clearly different from what you've seen before the device?
I have. I don't do the extensive amount of cavitational surgeries as other people have, so I would defer to some of the people here in the audience that have used the device routinely after their cavitational surgeries. But the science is certainly there, and there's some things I want to share here in just a moment that will maybe add some insight into that area for you as well. Chris?
As soon as my patients come out of the OR and I put them in the recovery room, the paddles go on their face right away. And usually after an hour or two, they'll start to get a little sore. The general anesthesia wears off, local anesthesia, and they walk out usually pain-free from this device. And I have them come in every day, 2 or 3 days after, and wear it for an hour and a half. You can't overdo it. Just the more they wear it, the better they heal. And I know Bob Kulaks uses it even before on his patients surgically. I just don't have that time, but it's amazing. And they just sit there. It's a no-brainer. You just wire them up and go. And
let me ask one more question that relates to that distally. in Germany we use a lot of hypothermia treatment for cancers and for viral infections as well. Could that be used for creating hypothermia in localized areas? I mean, how deep does the heat actually go, the heat effect?
The heat effect is fairly superficial, and we've removed the heat effect in experiments to see if there was a difference in the responses, and there was not. It is definitely the photoenergy that's doing this, but the warmth does feel good to the patient. There may be some synergism with a little bit of the warmth. It doesn't get extremely warm, but you know, we are doing some research in some areas I'm not privileged to divulge at this time, and they have to do with some of those same things that you're discussing. Yes?
Was asked over here, given that the angiogenesis properties, wouldn't it be contraindicated in cancer?
According to some of the more recent, the question as I understood it was, given the angiogenic properties of applying this device, wouldn't it be contraindicated in cancer? The only two types of patients I do not treat with this are ones who have active malignancies and ones who are pregnant or who might be. That's out of prudence. It's not based on science. It's medico-legal. However, the research recently on decreasing vascular proliferation in order to treat some of the malignancies, and I assume that's where your question is coming from. Are we not decreasing the body's response to try to get rid of this disease in the first place by shutting that down? I offer that as a question, not an answer. We are doing studies on both undersized fetus development and on melanoma and some others.